All right, just want to get myself on camera here and looking good. Welcome to Back Talking, the show where we discuss all things related to the back or spine. I'm Todd Wagurski, and I'll be your host for the show. Now, last week we ran the so-called pilot episode of Back Talking. We made it through the show without any technical difficulties, so this week, hopefully, everything will hang in there and we'll be able to pull it off and nothing breaks. So now I've been on the air now for about 10 months now with my podcast, also known as Back Talking. You can find that on iTunes or Stitcher Radio, but also with several web shows that were hosted on Google Hangouts. Now the Blab medium is fantastic, not only because of the visual element, but also for its ease of use. It's so much easier for people to jump in on the conversation. Now, as I said earlier, this show discusses all things related to the back or spine. And the advantage of the Back Talking show is that you get me, a real life person who has spent the past 20 years helping people with back pain. And I'm actually talking to you from one of my treatment rooms as we just finished up the morning session of seeing patients. So this is what I do. So now I realize that there's a lot of information out there. Some is good and some is bad. And my motivation for doing the show comes from several websites out there that have forums on them. And these websites deal with the spine. And on these forums, people with neck or back pain issues can come in and post about their issues. And they're looking to hear feedback from others from what they did under similar circumstances. Now, some of the advice is good, but most of the time, it's just plain bad. So who would you rather get advice from? Someone who has, not studied backs for over 20 years, or me? So the show is actually my way of giving back and trying to bridge that gap that exists between those who have questions and those who have answers. And not saying that I have answers for everything. If I don't, I'll go out and I'll find someone that does. So I'm excited about the show. And the format of this Blab episode is what I'm calling Spinal Grand Rounds, where I present a real-life case to you. And you can follow along and maybe see similarities between what either you're struggling with or someone that you know is dealing with. It's also meant to help educate you and help you learn about your back. So now last week, we talked about someone who was dealing with facet joint issues. So if you missed out on that, you can go to my website, backtalkinghelp.com, and you can find it under the video shows tab. And you can always reach out to me. You can email me at todd@backtalkinghelp.com. I'd like to hear from you, and I want to know what you're struggling with. So let's kind of jump into the show here, and let's see how things work. All right. Again, you can reach out to me, todd@backtalkinghelp.com. Let me hear from you. I want to know what you're struggling with. So we're going to jump into our case for today, and hopefully this is all showing up on screen. This is one of the things I'm working with, is trying to understand where my camera is and so forth. So our case for today, we have a 70-year-old male. He's retired, and he's an ex-office worker. His history is 20 years off and on of low back pain. And about 2 years ago, he started having bilateral leg symptoms, meaning he had pain, cramping, discomfort in both legs. Now that pain is sharp, it's frequent, and he rates it 6 out of 10. Standing and walking for a period of time, like between 10 and 15 minutes, increases his leg pain. And after sitting for about 10 minutes, his leg symptoms ease. And in the past year, he's had 4 epidural steroid injections. Now, his exam findings. He's a 70-year-old man. He walks with a cane due to foot and ankle arthritis. There's a limited range of motion exam was performed because he has major balance issues. He has a hard time just even standing, and that's hence uses the cane. Now, his lumbar spine motion, his flexion and extension, is limited to about 50% of normal. And there's no sign of nerve root tension. Now, we talked about this a little bit last week, and I just want to go through it again, what nerve root tension means. So it means that the nerve isn't being, there's no sign of it being irritated anywhere along its pathway. And I want you to think about it like this. So say I attached a string to your lower back, ran it down the back of your leg and onto the bottom of your foot. Now this string represents a nerve. Now if you were lying on your back and I were to keep your leg straight and raise it, the string would begin to tighten. If in that position, I were to then flex your ankle, that string would tighten even more. Now, normally your nerves in your lower back to the bottom of your foot glide easily, and they may even move over several inches. That's how much slack there is in your nerves. Now, this is what I want you to understand from this. Nerves don't like to be stretched. Stretching a nerve causes pain. So if there's anything along that path that inhibits normal gliding, the nerve begins to stretch and you get pain. Now in the back, nerves can be irritated by numerous structures, and most people quickly jump to the disc as being the most likely culprit. But nerves can also be irritated by muscles, such as in piriformis syndrome, or by bone, such as in arthritis with bone spurs, and stenosis, such as in the spinal canal or in the foramina. He's had imaging studies performed. He had an MRI about 9 months ago. His spine basically looks like a train wreck. He's got degenerative disc disease, or DDD, at all levels in the lumbar spine. He has degenerative joint disease, DJD, again, at all levels of the spine. He's got loss of disc height. He's got anterior and posterior body osteophytes, which are spurs at all levels. He has ligamentum flavum hypertrophy. That's a ligament we're going to talk about here in a minute. So he's got ligamentum flavum hypertrophy between L3 and L5. And he has severe canal stenosis at L4 and L5. So now, before we talk about pathology, you need to understand what normal anatomy is. So we're going to kind of diverge off. This is the education portion of the show. And we'll start talking about it. Obviously, we're going to start off on a grand scale. So we have the spinal column. The spinal column is composed of 24 bones and the sacrum, which is basically your tailbone, that bone in between your butt. The spine has 3 curves to it. It has 2 lordotic in the cervical, up in your neck, and lumbar spine. That means that it curves towards the front of your body. It has 1 kyphotic curve, meaning that it bends towards the back of your body, and that's in your mid-back or thoracic spine. Now, obviously, your spine, it's your structure. It's what everything hangs off of. But it also allows us to move. Obviously, that's one of our humans move. We want to jump, run, do what we do. But with those curves, it almost has a shock absorption design to it as well. So that's one of the other functions of it. So it allows us to move, and it absorbs shock. But also, the most important is it helps protect the spinal cord and nerves. So it has a function on 2 ends of the spectrum. Hey, I got to protect the spine and the spinal cord and nerves, but also I need to move, flex, and so forth. So I'm going to jump in. This is where I'm going to go out. We're going to show a few pictures. And I'm going to zoom in on the vertebral column. And hopefully this is all very elementary, but you can never really hear it enough. So here is Mr. Spine. I'm going to rotate him around. Let's get him to dance a little bit. And we'll get him to stop. Almost. Let me back off. Let me get him rotate. These are the curves I'm talking about. So you can see this is the low back, lumbar spine. It should arc towards the front, mid back towards the back, and the neck again towards the front. Now we're going to start zooming in. Here's the lumbar region. The lumbar region is composed of 5 vertebrae. In this spine, I don't know why, there is 6, but typically we have 5. 1, 2, 3, 4, 5, lumbar spine. Here's the sacrum. Here's the ilium. These are the top of your pelvis. I'm going to give this a little rotate around for us just to give you a frame of reference. Here is the spine. Here's the lumbar spine, our lower back. These are the bumps you feel when you palpate somebody's spine. These are called spinous processes. So here's the front of the body. Here's the back of the body. I'm going to show you a couple of, this is an x-ray of the lumbar spine. Here's the front of the body. Here's the back of the body. Nice vertebra. You can see the disc spaces in between. Here's the joints right here. Here's the spinous processes. Just wanted you to get a feel for what a lumbar spine x-ray looks like. Here's a normal lumbar x-ray or MRI. Same thing, block part of the vertebra up front. Here's the spinal canal. This gray part showing some nerves. The spinal cord actually terminates up here at about T12. It's called conus medullaris. Don't need to remember that. But here's a nice normal spine, nice normal discs. Everybody looking good. All right, let me pull back out a little bit. I guess over a little bit. All right. So moving on. We're continue to keep getting down a little bit closer to each. We're just kind of zooming in on the spine. That's just a better way to say it. Understanding normal anatomy, a functional spinal unit, just another fancy word for 2 vertebra. Here's the 2 vertebra and the disc in between, the intervertebral foramen right here. This is the hole opening. This is where nerves exit out. We have nerves, arteries, and veins that run through this hole. They usually run in a bundle through this hole right here. So we have 2 vertebrae, the disc in between, and this opening where nerves exit out. Here's a cross section. If we were to take what we just looked at, here's a little model. If we were to cut it in half, there's some anatomy I want you to see in here. The front part, or basically no, on this slide, what I want you to know or note is the spinal canal right here where I'm showing right here. This is where the spinal cord runs in this canal. And the borders of the canal are what's important. On the front, we have the vertebra. There's a ligament called posterior longitudinal ligament, not very important. Part of the canal is bordered by the disc. This part of the vertebra is called the pedicle, just a thick part of bone. This is the lamina, kind of the posterior arch of the bone. Also in between each vertebra is a ligament. This is called ligamentum flavum. Ligamentum flavum is a ligament that is elastic. It stretches. So when you move and then come back to your original position, this ligament will open up and then shrink back. So it stretches and then rebounds. It's called elastin inside that ligament so that it doesn't buckle. Imagine if it didn't kind of recoil back to its original length it would start to buckle into the spinal canal and maybe put pressure on the spinal cord or on a nerve. So this is what I want you to notice on this view. Spinal canal, we have borders to it. Disc, bone, 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 and a ligament. This is the same vertebra looking down from the top. Here's that canal I was talking about. Here's the vertebral body, the block part of the bone, like so. Here's that pedicle I'm talking about. We're starting to move towards the back of the body. Short pedicle. Here is a joint. Here's the lamina, the spinous process. The spinous process are those little bumps that you palpate on your back. So again, the vertebral body, pedicle, the lamina, spinous process. In between the vertebra was that ligament. You don't see it on this view. It kind of connects from one vertebra to another on the backside of the canal. So what is stenosis? You may have heard the term stenosis. Stenosis is actually a Greek word meaning narrowing. It's a general term that's applied to numerous pathological conditions, such as with arteries. You have narrowing caused by plaquing. You can see it in the colon from scarring, from like Crohn's disease. That scar can actually narrow the lumen, the inside of your colon. And also in the spine. This is where most people are familiar with it. And probably if you're on this discussion, this is what you're looking at. You have spine. It can either be in the central canal, where I was just showing you where the spinal cord resides, or it can be in the intervertebral foramen. If you remember back a couple of slides, or on here, this hole where the nerve is exiting out. So you can have stenosis of the canal right here, or stenosis of the foramen. And again, stenosis means narrowing. That's all you got to remember. Stenosis means narrowing. Spinal stenosis is typically caused by degenerative changes in the spine, wear and tear, what people call aging. It can be caused by any structure encroaching on the spinal canal. So here again, we have this view, that cross-sectional view. Stenosis, narrowing of the canal here, can happen from the disc. The disc can bulge. It will herniate into the canal. Pedicle, this short piece of this bone piece here, can be congenitally short in some people. It's like you're just born that way. And this is common in dwarves. They have short pedicles. And you may have heard about athletes. They get a neck injury or a back injury, and the next thing they say, oh, my doctor has advised me to stop playing football. This is typically the condition. They have a short pedicle, meaning they have a shortened canal. It's a narrower canal, which can increase the risk of injury. Osteophytes. Osteophytes are spurs. Spurs can form off of the backside of the block part of the vertebra. And those spurs can start to encroach on the canal. We can have facet arthritis. Facets are the joints, and you're going to see a couple of pictures of them coming up. Facets are the joints, and when they get arthritis, they get bigger. The bone hypertrophies, and that bony overgrowth starts to impinge or encroach on that canal. And finally, ligamentum flavum, that elastic ligament I just was talking about. As we age, it hypertrophies, it gets thicker, it gets bigger, and it loses that elastic capability, that ability to stretch and recoil back onto itself. So ligamentum flavum hypertrophy, we can have facet arthritis, osteophytes, pedicle, disc, anything that encroaches on the spinal canal can cause spinal stenosis. So here's a picture of a disc. This is what I'm talking about, causing spinal stenosis. Here's a herniated disc. This is a protrusion. It's narrowing the canal. This is what I'm talking about. This is where the spinal cord rests. It resides in here. Now, what I want you to understand is that the spinal cord takes up about 1/3 of the canal. So only about 1/3 is occupied by the spinal cord. That leaves 2/3 for slack. There's a lot of, that the spinal cord has a lot of movement. But a disc, a protrusion here can shorten up the canal. This is an extrusion, just a central extrusion. You can see this guy's sitting right in the middle of the canal, causing stenosis. And here's a picture. Here's an MRI of a disc herniation. And here's the spinal canal right here, this nice white structure. And you can see how far this disc bulge, how much it encroaches on that canal. Here's facet arthropathy. This is what I was talking about. Bone overgrowth causes them to enlarge. Degeneration, arthritis, we get spurring. It's starting to wear down. Here's the progression. Here's the spinal canal. Here's the joint. You can see in this slide A, they're getting bigger. Slide B, look at the bony overgrowth here. They're getting bigger. Slide C down here, if you can see this. These joints are getting huge. There's almost obliteration of the joint space. And in slide D, look at the size of these facets. It's huge. It's impinging on the canal. So facet arthropathy. This is degenerative joint disease, DJD. This is them. Ligamentum flavum hypertrophy. I'm going to show you a picture of this. Let's see, computer freaking out a bit. Let me cast this. And why is it doing that? Technical difficulties here. Hang with me, folks. All right, of course, this worked beautifully. So that one works. Let me jump over. Why are we in a mini screen? Ha. Let me see if I can shrink this down. Oh, brother. Gotta love technology. Well, we may have to skip over this. Let me try one more time. And why it is in such a small screen. Let me try one more time, one more thing. So we jump in, we get this. This works beautifully. Sorry, folks, bear with me. And uh-oh, now my computer, of course, has crashed out. Wow. Okay, well, I had a nice picture for you, and let me get everything back up to speed here. Sorry, folks. All right, I'm going to pull this up, and maybe later we can do some fancy editing somehow. Everything is rebooting. My computer actually shut down and it is rebooting. So we pause for technical difficulties. And where I'm at, I'm here in North Carolina. It has just started raining. I'm in Raleigh, North Carolina, just outside. And let me see. kind of making an end run since my computer. This worked beautifully earlier. Let me refresh this. All right, let me see if I can jump in. Stenosis. Okay, here we go. Let me see. Now this is ligamentum flavum hypertrophy, as also coupled with a disc bulge. Beautiful image here. Lumbar spine. Here's the black part of the vertebra, these gray things in between, the disc. Here's the spinal canal, this white. These are the spinous processes, those things I keep talking about off the back of our spine. This green line is showing you where the disc bulge is. It's starting to pinch. The yellow is the ligamentum flavum, and it is encroaching. You can see this narrowing right there. Look how nice and fat it is up top. This is stenosis. This is stenosis right there, narrowing. And let me slide up and down. You can see how it narrows. Here's the green line. That's the disc bulge. Almost no canal in this view. Here's the ligamentum flavum, the disc. This is totally cut off at that segment, at that level. And again, out more laterally. Canal stenosis from ligamentum flavum hypertrophy. Okay, so I'm going to jump back in. This is old. This is how I used to do it when it was a pain in the butt. And let's cast this tab. Let me just back up. Let's see. It jumped ahead on me. Ligamentum flavum hypertrophy. Okay. So in our case, we have our 70-year-old man with just degeneration everywhere. He's got degenerative disc disease. He's got degenerative joint disease. He's got ligamentum flavum hypertrophy. He has canal stenosis. Now, the clues to this case are standing or walking for greater than 15 minutes increases his lower back pain. And the MRI finding of canal stenosis. Now, those are the major clues. Now, what I want you to understand about why these are clues is that when he walks for 15 minutes, 10 to 15 minutes, his leg pain increases. And also the MRI finding of canal stenosis. Now, stenosis is the key with imaging. Stenosis is stenosis. There is narrowing of the canal. And unlike disc bulges in the lumbar spine, if you remember the discussion from last week, where we have a high degree of false positives, like 33% in the lumbar spine with a herniation. So 1 out of 3 people have a disc bulge, but it's asymptomatic. And in the cervical spine, it's 50%. So there's a lot of false positives when you see a herniation, but not when you see stenosis. Stenosis is stenosis. Stenosis is the cause of the trouble. So understanding his condition. So he's got stenosis. He's got neurogenic claudication. We'll come back to that in a second. Osteoarthritis. He's got degenerative joint disease. He's got disc disease, as I've mentioned a couple of times. Now, a neurogenic claudication. You're like, what is claudication? Now, claudication means limping. And with neurogenic claudication, the patient feels a pain cramping, tingling, or weakness in the legs. And the differential, it's called a differential diagnosis with numbness, tingling, weakness, cramping. It's either neurologic or it's vascular, because it can also cause tingling, numbness, and such. It's like when you fall asleep on your arm and you go, holy cow, it's tingling, it's numb, and you feel it start to come back alive. That's vascular claudication. So neurogenic, the differential here is that it's aggravated by walking and prolonged standing. And it's classically relieved by a change in position, such as bending forward at the waist or just changing position. So that's the differential. With a vascular condition, rest will alleviate it. With neurogenic, rest doesn't alleviate. You have to change positions. So that's the differential. So this guy, when he sits, he feels better. He's changing position. It's also, what's funny about this is it's called the shopping cart sign. You see people with stenosis that lean on the shopping cart, rather, they're bent forward and they feel better. So his treatment at this time, remarkably, it's all palliative. He responded quite well to acupuncture, of all things. But typically people with stenosis, they're a surgical candidate. It's either through a laminectomy, where they go in and actually remove part of the backside of the vertebra to decompress and take the pressure off. So in this guy's case, he has it at so many levels. You could not go in. It's the joints as well. There's so much involvement that he's really not a surgical candidate at his age. He possibly, if he was to have bowel and bladder problems, but typically at his age with this level of involvement, you're just going to do palliative care, something to make him feel better. So Q&A time. I don't see anybody out there that has any questions, comments. So just want to kind of talk next time. I'm going to be here next Friday at 1 p.m. And my topic of this discussion is going to be spondylolisthesis. So hope you enjoyed this. Tried my best, learning, getting better. Technical difficulties, they arise. But if you have a topic for discussion, please email me at todd@backtalkinghelp.com or leave me a question here on this blab. Let me know. Let me know what you're struggling with. I'm going to get myself back on camera. Here I am. So again, reach out to me, Todd@backtalkinghelp. I'd like to hear from you. Let me know what you're struggling with, or pass this on to somebody that you know is having problems. Have them shoot me an email. It could be a future show episode. So let's talk. Thanks a lot, everybody, and I'll see you next time.